Hey, welcome back. We're going to talk about inflammatory and valvular heart disease. So, in the image, we see the three types of inflammatory heart disease that we're going to be discussing. So, we know that the whole process of the inflammation, whether it be of the muscle, the valves, or the surrounding layers, is going to have an overall effect on your cardiac output. So then we're going to examine the varying levels of the inflammatory heart disease. So we're going to start with endocarditis, where you're also going to see that we're going to refer to that sometimes as infective endocarditis. So this is going to be in the inner chamber of your heart where blood is flowing, and you have your valves, and if we have any kind of vegetation or growth or structural changes, the bacteria can get stuck there and proliferate. And that's how that inflammatory process is generally going to start. Myocarditis will affect the actual muscle. So you can understand that if you have a very sore muscle, that's going to have a profound effect on your cardiac output. Whereas pericarditis can affect the heart sac. And that's usually because of the inflammatory process we associate with fluid accumulation, pain, redness, swelling, all that stuff from way back when in first semester. And actually what's potentially going to happen with the pericarditis is that pericardial sac is going to accumulate more fluid than should already be there. So we've said that generally speaking, we're talking about a very low number for fluid in the pericardial sac, 15 to 50 milliliters of fluid to help protect the heart and cushion the heart. When we have more fluid accumulation, what's going to happen is the pressure, because it's a finite space, is actually going to assert itself as the heart's trying to pump, and it's going to make the heart pump harder to overcome that extra pressure. And that's going to end up with what we're going to call cardiac tamponade. So with endocarditis, we have that whole inflammatory disease process. It's in the surface of the heart, so it can have an effect on the valves. Generally speaking, it is going to be treated with penicillin. However, one of the things that we want to make sure that we do with these inflammatory disorders is that we're going to culture both the throat and we're going to obtain a set of blood cultures so that we know how better to actually treat the inflammatory process itself. Two forms. Don't care that you're really aware of a subacute or a acute form, because generally speaking we don't see that as documented with our client's history. Just know that generally speaking, if you already have a pre-existing valvular heart disease, that we do have that chance that bacteria is going to get stuck there for those structural changes that you would have for any calcification, and that bacteria is kind of going to proliferate to make that inflammatory disease process. The acute form is generally just with people who have healthy valves. So we know then if once we get these kind of inflammatory disease processes once, we're highly likely to get them again if we don't do the things that we're supposed to be doing. With infective endocarditis, or IE, the most common causative organism is Staphylococcus aureus or Streptococcus viridans. So we have those under or not treated infections that make their way to the lining of the heart. With myocarditis, that's where the actual heart muscle itself is going to become inflamed, and that's going to lead to a lot of myocardial dysfunction, decreased cardiac output, the potential for dysrhythmias, and you name it. But what it essentially means is because I have this inflammatory disease process that's happening, I'm going to end up with a bad pump, and that's why we have all those changes to how well we're able to maintain cardiac output. Pericarditis can happen in a client who has experienced an acute MI. So we have two various syndromes here. So again, much like the earlier where we had the acute, this is going to be acute pericarditis, and that usually occurs within the initial 48 to 24 hours after an MI. So well into what we would hope would be that healing process. The other one is a Dressler syndrome. So that's just a form of pericarditis that is going to appear much later, typically 4 to 6 weeks after an MI. So the underlying issue we can see is that we're going to have some kind of structural changes. We're going to have that inflammatory process happening, and those clients who have had an MI are going to be at an increased risk. So we need to do a lot of patient education to help them understand how important it is that they take care of themselves and participate in cardiac rehabilitation. With pericarditis, what we say is this hallmark finding, this expected finding, although it is expected, it is still a complication, of a pericardial friction rub. So again, that's if you take your fingers into your hair and you rub the hair together, that's the sound that you would be hearing when you're auscultating heart sounds. This inflammatory process can lead to what we know as chronic constrictive pericarditis, and that's just that whole process of where we lose elasticity from the scarring of the pericardial sac. That loss of elasticity is obviously means I lose that stretch, so my heart cannot pump as effectively. So with our health promotion and disease prevention categories, we know that early treatment and correct treatment of those infections can help prevent what's known as rheumatic fever. This does not happen a whole lot anymore. Rheumatic fever in children usually will lead to some sort of inflammatory disease process, but it's just not common like it used to be. We can think about prophylactic treatments, including antibiotics for clients who have cardiac defects. I see this still in a lot of our med-surg books and in some of the literature, but I would say that just prophylactic treatment has kind of looked down upon just because, again, of the risks for clients not doing what they're supposed to be doing with antibiotics. And then generally we know that the longer you take something or the more you take something, we're more likely to develop a resistance. So there is still some debate out there. But the biggest one, as with most things from a health promotion and disease prevention, is to make sure that they are getting the influenza and the pneumonia vaccinations, especially in the older clients. And we would do this to help decrease the incidences of myocarditis. So risk factors, pretty straightforward. You have any kind of recent bacterial, viral infection, could be fungal, a history of a prosthetic heart valve, any kind of IV drug use, autoimmune disorders, chest trauma, and of course we talked about the post-MI inflammation. So here we kind of see the inflammatory disease processes because of the virus or bacteria. We are seeing our clients present with weakness, shortness of breath, they have arrhythmias, they have changes in their hemodynamic status because we have a bad pump. Everything under the sun is a complication. So think heart failure, cardiac tamponade, which we're going to investigate further, the risk for clots, so stroke, pulmonary embolism, acute limb ischemia, and of course arrhythmias, because we're going to have that irritation to the actual heart itself or around the heart or in the heart. So IE is most common in clients who have structural issues such as cardiac devices, pacemakers, prosthetic heart valves, or again, IV substance use disorders. If they are having any sort of invasive procedure, dental procedure, you think about all of the dental hygiene and how much of that gets basically sprayed down our throat when we're having those kind of dental procedures. We do see evidence of some happening because of body piercings and tattooing. I will say that that is less and less, and that's probably more related to people who aren't seeing a credible piercer or tattooer. We do know that if you were to be tattooed or pierced by somebody who is less than qualified, it could lead to bacteremia, which is going to lead to all of those inflammatory disease processes. But in this particular case, we're talking about infective endocarditis. So things that we need to look for, expected findings with IE, is a positive blood culture. Notice we're saying blood, and really when we say blood cultures, for my students, they know that this should be from 2 different sites. So generally, if they have a central line, we can get one from the central line. If they don't have a central line, we'll have to go to 2 different blood draws. So maybe one from the left arm, one from the right arm. And then for the second set for the central line, obviously we don't want to go to the same place for that second set of blood cultures. This particular expected finding, petechiae, which is purplish discolorations, you have basically your capillaries are kind of exploding, and we end up with that purpura. It is expected in infective endocarditis. So, although normally we talk about petechiae being a very bad thing, it's a very ominous sign that other things are going on. Till we rule out infective endocarditis, we just kind of have to assume that that's an expected finding. Obviously, it's still an inflammatory disease process. It's still an infection. So we're talking about fever, flu-like manifestations. Because of the structural changes, especially in the acute, you can hear a murmur. And then the other one is you can see splinter hemorrhages, red streaks underneath the nail beds. Again, this is not something that I have seen a whole lot of, specifically the splinter hemorrhages. So with rheumatic endocarditis, remember that is what we're talking about with the children who have or had an undertreated kind of upper respiratory infection. So same processes, just a different name. So this is an infection of the endocardium due to the complications of a rheumatic fever. Expected findings: chest pain, lack of cardiac output. So we're going to go ahead and treat this prophylactically as an MI. You're going to go through the processes because it is new or recurrent chest pain, and making sure we get a new 12 lead. Generally speaking, if they're already admitted for a endocarditis, we'll get that 12 lead, and it will probably say, that there's ischemia somewhere versus that they suspect there's an actual MI. So that is going to be that demand chest pain that we talked about. So your heart wants to be able to perfuse, but when it has inflammatory processes happening, it has a bad pump. Obviously, shortness of breath, tachycardia, friction rub, murmur, fever. We talked about rashes on the trunk or the extremities. Most, I said, in the little pop-up box there, the blue box, I said all of these signs and symptoms are related to a decrease in cardiac output. The rash is debatable. With myocarditis, we can clearly see the inflammation of the heart muscle in the picture to the right. Notice that the signs and symptoms are pretty straightforward. Chest pain, tachycardia, dysrhythmias, murmurs, friction rubs, cardiomegaly. If you do have a friction rub, we're probably thinking along the lines of something more than just myocarditis, but we won't know until we actually do some further investigation. Pericarditis, again, this is going to commonly follow an undertreated respiratory infection. It, again, can be due to a myocardial infarction. You can have debilitating chest pain. Narcotics are not advised for this type of pain because they're going to mask the signs and symptoms. Remember, we're treating the underlying cause, and since the underlying cause in this instance is an infection, we want to be able to make sure that the antibiotics are doing what they're supposed to be doing. You know, we're not going to be drawing WBCs on these guys every day, so we have to have these other tools to tell us whether or not our interventions have been effective. Typically with pericarditis, because this is the sac and it's going to interact with the lungs, we can say that pain is going to be aggravated by breathing, coughing, and swallowing. Pain is worse when in the supine position because of the increased pressure in the thoracic cavity, and may be relieved by leaning forward. Very similar to what you see your COPD patients have. So now if you have issues with pericarditis and you also have other underlying comorbidities, you can see how that may become really confusing. Are you leaning forward because it's pain relief, or are you leaning forward because you have COPD and it's easier to breathe? When we look at a pericarditis client, it's probably a little bit of both. So long-term heart failure, or what we're going to call cardiac tamponade, remember that is where the pericardium fills with fluid. It exerts pressure on the heart, making that heart a less effective pump. Later on, we're going to say that cardiac tamponade is going to be a medical emergency. So things to think about, and this is semantics here. This is NCLEX 101. You know, the words I always see in our textbooks are muffled heart sounds. Muffled heart sounds are the same as decreased heart sounds, are the same as diminished heart sounds. So if you guys think about, we always tell you that we're not trying to trick you. We're not trying to trick you. It's diminished, decreased, muffled mean the same thing. It's just I know a lot of faculty feel that if we put muffled on there, that's a dead giveaway. It makes it a knowledge-based question rather than something that's more application or analysis. It's still a medical emergency, and we're going to prepare that client for pericardiocentesis. Of course, we're still talking about getting a new ECG because they're going to complain of that chest pain. And you can see this ST segment elevation because of the ischemia, because of the inflammation, and you can also see atrial fibrillation. So with this illustration here, we see the inflammation of the pericardium. We see the causes. You see your little stick figure in the lower left-hand corner that we see increased pain when you're lying flat and decreased pain when you're sitting up. All right, we do see ST elevation. We also see PR depression. I don't really teach my students about PR depression. And then we can auscultate that pericardial friction rub. So because of the ST segment changes, we still are saying
that could potentially be a myocardial infarction. So again, we're going to treat it exactly the same. With cardiac tamponade, what we want to watch for are the 3 Ds. So distended neck veins, JVD, distant, decreased, diminished heart sounds, muffled heart sounds, and decreased blood pressures, especially when we start to see changes in the heart rate, where the heart rate is going up and the blood pressure is going down. You can obviously see that they are headed towards shock. In the illustration, what you see on the left is a normal pericardial sac. Now, here I see that there is a lot of fluid that has accumulated in that pericardial sac. And again, you know, that heart is trying to beat, and when it beats, it tries to beat outward like that. And the pressure of the fluid is pushing that heart in, making it less effective.
Diagnostic testing, most importantly for us starting out, are going to be blood and throat cultures. Again, those are priority and they need to happen before I throw an antibiotic on that client. So if you're seeing something and the practice questions are talking about, you know, what is the first action a nurse should do when caring for a client with an itis, the answer is going to be blood cultures, blood and throat cultures, so that we can understand how to treat it. What is that organism going to be susceptible to? Because an echo will provide us with great information about the structure and blood flow, it helps us identify or detect things called vegetation. Vegetation are just growths. They're usually growths around the valves, and that growth, whether it's calcification, whether it's any kind of already bacteria or whatever, is going to harbor and allow bacteria to propagate. The echo would also give us information about a pericardial effusion. Again, the effusion is just another way of saying that, hey, we have fluid in the pericardial sac. On our ECG, you may see ST elevation. It's typically in all leads for pericarditis, which is going to be different than a true MI, because we know an MI may not show up in a lot of the leads. We're going to be looking for conduction blocks, because that heart tissue itself is actually inflamed. We can do cardiac MRI or MRA. Don't see it done a whole lot unless we're thinking, you know, they're having other underlying issues that may be presenting or being covered up by the infectious disease process. Of course, we're still going to look at our ESRs, our CRPs, our lactic acids, our WBCs, because those are all going to be markers of inflammation. And yeah, I would still want a set of troponins and a BNP at least early until I've ruled out a myocardial infarction. And this is typically what you'll see. You'll get in this client and they'll be diagnosed with one of the inflammatory heart disease, and kind of, instead of having that normal kind of 3 sets of troponin, we only have 1 troponin, because we're like pretty sure that the chest pain is related to the inflammatory process and not to an actual MI. So what do I need to do? Notice that the plan of care is general, and it is for all inflammatory disease processes. We're still starting with airway, breathing, circulation. So we're going to give oxygen as prescribed, titrate oxygen to maintain SpO2s, frequent vital signs, especially being getting a good temperature, reviewing any kind of ABGs, our SaO2s or SpO2s, look at your chest x-ray results, see if there's any cardiomyopathies, cardiomegaly. You're going to monitor for cardiac tamponade. What you're going to see again is kind of changes in the vital signs over the long term. So we're going to trend that information. You're going to listen to your friction rubs, monitor the ECGs closely, and monitor for embolization. Again, it's still focusing around airway, breathing, circulation. So they talk about bed rest. So bed rest obviously begins with bed rest. Blood and throat cultures. Again, that's one of the first things that I would do. Echocardiograms and monitor for dysrhythmias. Your goal is to restore perfusion, evaluate your interventions, monitor for increasing shortness of breath, monitor for symptoms of a relapse, and then monitor for thrombolytic therapy because of the increased risk for embolization, especially if we have a PE, MI, or stroke. Here is cardiac tamponade. It's compression. We've talked about that. It involves something called Beck's triad. Beck's triad is just a fancy way of saying what would I expect to see in this client. And the three things that I would expect to see are distended neck veins, distant heart sounds, and hypotension. It's still basically the 3Ds. So you're talking about distended neck veins, distant decreased heart sounds, and just change hypotension to decreased blood pressures. So you're looking at your Ds. Over here, what we see is a pericardiocentesis. Under guided ultrasound, we're going to go in, we're going to use a needle to decompensate or aspirate all of the fluid surrounding the heart. Now imagine I have a big needle, it's going to your heart, and if I go a little too far, I'm going to nick your heart. And you may end up with a contusion on your heart, which is another complication. So what do I need to look for to see if they're headed towards cardiac tamponade? Pretty straightforward. Dizziness, dyspnea, chest pain or tightness. You see your perfusion words, increasing restlessness, pulsus paradoxus. I've never gotten a client in my life with pulsus paradoxus because who is sitting there monitoring that blood pressure for a decrease of 10 in the systolic blood pressure during inspiration. That's great. If you're in the ICU and you've got an ART line or we've got some sort of intense cardiac monitoring on you, you can certainly do it. But we're not going to be assessing for pulsus paradoxus on a step down or a med surge floor. It's just impossible. You do see the new tachycardia. Now, if we start to see changes where that heart rate goes up and blood pressure is going down, we're getting increasingly worried. Still muffled heart sounds, still JVD. And again, this cardiac tamponade explains Beck's triad. Again, you see the 3Ds. If you see those three things, you need to run and get help. It's cardiac tamponade. We're going to send them down for pericardiocentesis. The other two that we see here, if we're talking about acute pericarditis, we've talked about pericardiocentesis. Usually we said if you get these once, you're more likely to get them again. So you may end up needing a pericardial window, which is where we're actually going to go in and we're going to cut away a section of the pericardial sac to allow that extra fluid to just be reabsorbed in your thoracic cavity. And the last one, the most invasive one, is going to be a mediastinal drain. And again, I don't test my students over a mediastinal drain because it's just not that common for us where I work. So, thinking about that, we like to give you these little tools to help you remember. Big JVD, extreme hypotension, can't hear heart sounds, pulsus paradoxus, ECG changes, or too tight. It's tamponade. So it's Beck's PET, Beck's triad. That's telling you that it's probably related to tamponade because we know it's those three things, and then the other signs and symptoms that we would be looking for. It is an acute medical emergency. We need to do something quick. They are going to decompensate very fast. Our client-centered care remains much the same. We're going to cluster care, limit their activities, allow them rest, obtain those blood cultures, assess pain, OPQRST, administer pain medications as prescribed. So earlier I said, okay, we need to be careful of narcotics here. That does not mean that we're not going to use them. I'm just saying in NCLEX world, before you use them, you need to understand that they could mask signs and symptoms. Look for complications. We talked about clots. We've talked about heart failure, cardiomyopathies, dysrhythmias. And just make sure that they're telling us if they have any new kind of signs and symptoms related to what we would consider chest pain, that we need to know that right away. Again, new or recurrent chest pain is going to require an ECG. And again, we're going to look at it and then adjust our care plan. Here in the image in the upper right, you can see this looks like cardiomegaly, except for one thing. This is whiteout. So this is telling me that there is fluid accumulation, and that fluid accumulation is in the heart. So you can see that that would be a very serious issue for that client. We've talked about penicillin. Again, it's broad spectrum antibiotic, but you still need that blood and throat culture. Antipyretics for fever. So again, we're talking about acetaminophen. We can use NSAIDs for pain control. I know what you're all thinking. Oh my gosh, I want something better than an NSAID, but it doesn't have to be a PO NSAID. Toradol is an NSAID. So we can do other things that are going to help with that inflammatory disease process that don't revolve around morphine, fentanyl, or Dilaudid. We can also expect, because it's inflammation, that we would see some sort of use for prednisone. Of course, we know with prednisone there are a myriad of complications. I may need to start doing blood sugars on them. Of course, I need to monitor their electrolytes and just make sure that they're finishing their entire regimen of that corticosteroid. One of the things that I see my students do on some of my exams or previous exams for like respiratory or neuro is that, we'll put a random distractor in the ABCDs, and it's about PRN corticosteroids. We just don't do that. And that's one of the things that, I need to encourage people to make sure if you're looking at information about a prednisone and it says PRN, that is just not something that we're going to do. We could use digoxin because digoxin typically would make the heart a better pump. Again, this is not something that I see a lot of because of the increased risk of digitoxicity. And we've talked about what those signs and symptoms look like. We're generally going to look for nausea, vomiting, fatigue. You have muscle weakness, changes in LOC, the yellow halos, okay, loss of appetite, that's your anorexia. What's not on here is arrhythmias, because we may need to use an antidysrhythmic because of the hypoxia. And then we have our drug alert that talks about, hey, if you are caring for a client with myocarditis, you need to be careful in the use of digoxin. For endocarditis, we can expect IV antibiotics for about 4 to 6 weeks based on the cultures. Again, antipyretics, anticoagulation, especially if it's involving a prosthetic valve. Myocarditis, we can use beta blockers. Beta blockers are going to decrease myocardial O2 consumption. ACE inhibitors are going to help prevent the remodeling that's going to be related to that disease process. And we can also use IVIG for viral myocarditis in children. So for pericarditis, again, we're talking about NSAIDs, indomethacin, ibuprofen, things that are going to help that client become more comfortable. You can do colchicine, and we've talked about corticosteroids. We've talked about a pericardial centesis. It's the insertion of that needle into the pericardium to aspirate that kind of fluid. And again, if you've had cardiac tamponade once and we have not treated the underlying cause, you can have issues with the reoccurrence of cardiac tamponade. So what we're looking for kind of as we're caring for these clients is just the resolution of any kind of inflammatory disease process. No fevers, their WBCs are going down, the lactic acids are going down. They don't have any serious complications such as an embolus, and that they have improved cardiac function. That is it. Pretty straightforward for inflammatory heart disease. We talked about the big takeaways of making sure that we are getting a set of blood and throat cultures, that we're making sure we're auscultating heart sounds, frequent vital signs, that we are treating their pain appropriately. All right, if you have any questions, let me know.